In a world overrun with the fake, delusional, and disingenuous, he stands as a beacon of truth. He is Abuki Cabal. You are listening to Abuki Cabal.
Welcome to the Abuki Cabal Show.
What's going on, ladies and gentlemen? Shout out to all my subs, folks who enjoy the show. Please take a little time out to hit the like button. The one or two of you who have been hitting the dislike button or the thumbs down, I appreciate y'all too. If you could leave me a comment as to what you don't like about my comment or my content, I'd appreciate that as well. Maybe I can address some of that today. I'm going to take a look at some things that are going on in the medical field with regard to nurses. I think some physicians are also having some similar situations arising. But I was thinking about this the other night. BGS was talking about a lot of things that he's been talking about for years regarding some impending situations. I like to call them impending doom, and some of these things have been hovering around and we've known about it, him talking about it, things that I've heard about in my field that have been kind of lingering around forever. But people just choose not to do anything about these problems, and as if they're just going to go away on their own. And this just kind of made me just want to go ahead and talk about this a little bit, because I think it's kind of pointing in the same direction. I think a lot of things are going in a bad direction at the same time. And we will end up seeing some of these things start to intersect. And we're going to we'll take a look at some of that. Right. So this one story is about the 500K nurses that are leaving the bedside by the end of 2022. And what kind of problems that this may cause for the healthcare field in general, especially with COVID being around and not enough people, ancillary staff, nursing staff, physicians to be able to handle the problem. So let's take a look at that. All right. I'm going to go ahead and start with this one. Well, maybe I shouldn't start with this one. I'm going to start out with what the American Hospital Association is saying about this problem. Okay. And this is what Mr. Richard Pollock, President and CEO of American Hospital Association, had to say about this problem that's coming up. Okay. And he's talking, let's just go on and get into it. For 2 long years, the dedicated women and men, notice how they changed that up. One of the other problems that we're having, that we discuss about how, this change is happening where, men are secondary to women, traditionally it's been men and women. Now it's women and men of America's hospitals and health systems. Oh, man. All right. Well, let's get into it. Women and men of America's hospitals and health systems have experienced firsthand the overwhelming impact of COVID-19. The pandemic has been frustrating, exhausting, and heartbreaking. And few have felt these emotions stronger and longer than those on the front lines of delivering care. While there is always room to build on our efforts, the hospital field has worked hard to prioritize the safety, protection, and well-being of our caregivers and other essential workers. The healthcare field entered the COVID-19 pandemic with long-term challenges related to the workforce. Excuse me. In 2017, more than half of the nurses were age 50 or older. Almost 30% were age 60 and older and older. Federal data shows that we are expecting to lose 500,000 nurses by the end of this year, many through retirement, bringing the overall shortage of nurses to 1.1 million. However, due to the significant shortages of faculty, classroom space, and clinical training sites, nursing schools actually had to turn away more than 80,000 qualified applicants in 2019. Hospital employment overall is down 95,600 from pre-pandemic levels, according to the consulting firm Altrum. Because our workforce is our most precious resource, hospitals and health systems are committed to supporting them today, preparing them for tomorrow, and building a pipeline for the future. That's why our field has created programs and developed resources to promote caregiver well-being and resiliency. Examples include helping to pay back student loans, providing childcare and transportation, offering tuition reimbursement and training benefits, providing referral and retention bonuses, and supporting programs that address mental health and physical health. All right. Hospitals are also developing new team-based care models that allow healthcare workers from various disciplines and specialties to provide customized patient-centered care. This allows them to manage medical and social needs across all settings to improve care and enhance professional satisfaction. At the same time, many hospitals are facing serious financial pressures, including rapidly increasing costs for hiring and retaining staff. Through November 2021, labor expenses increased 12% compared to pre-pandemic levels, according to the consulting firm Kaufman Hall. And when looked at through the lens of expenses per adjusted discharges, meaning labor costs per patient, the increase was a staggering 19.5%. Persistent staff shortages caused by the pandemic have forced hospitals to increase their use of contract workers to fill nursing, technician, and other essential positions. Unfortunately, some staffing agencies are exploiting the severe workforce shortages by charging uniformly high rates and retaining up to 40% or more of the amounts for themselves. Okay. The conduct of some of these staffing agencies could suggest widespread coordination and other abuses, which is why the AHA, American Hospital Association, if you guys didn't hear that earlier. Okay. Which is why the AHA and the congressional lawmakers have asked federal agencies to investigate possible collusion and price gouging. Meanwhile, okay, you're going to make a claim before an investigation has ever been done against these people. I'm going to stop there for a second. Okay, these agencies are starting to actually pay nurses what they actually deserve to be paid. Anytime you go into a facility and you're the only nurse for, 22 patients, and you are tasked with, running IVs, making sure that these people are not having any kind of adverse reactions, calling the physicians, passing medications on these individuals. If anything happens, you got to call the physicians and get new orders. There are any number of things you have to do. Also, you have to do documentation on all those patients. Ideally, one nurse should have anywhere from 4 to 6 patients, if you're staffed appropriately, depending on what the acuity levels of the care for these patients are. If these patients don't have anything going on and pretty much, they're gonna not require a whole lot, that's one thing. But if these patients need constant attention, they're on pain medicines, like I said, they're on antibiotic therapy, they have wounds or things of that nature. If they have dressings that need to be watched, if they have drains or anything where there's there are things that have to be watched constantly, then that's a high acuity level. Okay, so if you're doing that, then that's too much in order. For you to have, if you have anywhere from 6 to 8 patients, that's a lot. Okay, if you have high acuity level, now imagine being one nurse and having 22 patients. And you may have 6 of those who have a high acuity level. Okay. Now, you may used to be able to, they used to pay nurses, $12 an hour to work that, then it went up to $18 an hour to $20 an hour, and then it went up to, well, actually, it was around 20, mid 20s, to high 20s for LPNs. For RNs, it was around 30 to mid 30s. So excuse me, that was pre-pandemic. Okay, after the pandemic, those numbers started getting closer together, but if you look at it, LPNs tended to have more patients than the RNs. The RNs tended to have, their 6 to 8 patients, and had better working conditions, had a little bit more staffing, whereas the LPNs were being trashed across the board. So then when the agencies came in, those numbers came up, and you could bid on what you were willing to go and staff. And on top of that, you're working in conditions where you were not safe. You didn't have proper protective equipment. You were overwhelmed with the acuity level of patients who had respiratory issues, who had all kinds of issues that you had to watch round the clock. If they went bad at any time, you had to send them out to another to an emergency room situation or emergency department, so that they could be put into the hospital if you were in, say, long-term care, or if you were in an LTAC situation, you could care for these patients because you have vents and all those things there available to you. But the normal levels of vent usage were totally different than after the pandemic started. Not to mention, the equipment that we started out with was just enough to get by. What we ended up with, towards the end of it, was what we should have had in the beginning, and not to mention some of the things with regard to, administrators, stockpiling and hoarding equipment and making you use equipment for longer periods of time because they didn't know how long, they would be able to run at the levels that they were at. And this was across the board. This was at the VA in the VA system. This was in the state hospital systems. This was in private hospital situations. You had the same horror stories all across the board, you know? So, I mean, you have people who you had situations where you had cross contamination going all over the place. You have some nurses who started to buy into the misinformation that was going on out there. I mean, it goes on and on and on. You know, right now the VA has the self-contained systems where they have the helmets and the jumpsuits where the whole system is self-contained, and it feeds itself its own purified oxygen or filtered oxygen. That's 10 times better than what the majority of us have out here. The majority of us are wearing, wearing the same mask, for a week at a time, sometimes longer, if we're not buying our own equipment, and then we're not being paid what we should be getting paid for the number of patients that we're actually caring for. And you have the Hospital Association here, moaning about, what we're being paid through agencies, whereas what we're being paid if we stay within the hospitals and within the other healthcare facilities, we're being paid much less than that and treated a lot worse. So then, because now we're being paid closer to what we think that we should have been paid in the first place by putting ourselves on the line. And I can't tell you how many nurses have been seriously injured. The treatment that you got, that we had to receive from family members, the attacks that take place, the verbal abuse that takes place, what else? The numbers of nurses who were infected because of not having the right equipment, then having to go out and be treated. Some of them returned to work. Some of them died. Some of them had to go in and be trached, be on vents. One nurse that I worked with, she got COVID and she just started to be able to get out. She's been for months. She has been hospitalized. And she's just now starting to get out and get to some semblance of normalcy with her life. So there are other people who didn't have that same result. But when you have the risk of that taking place, and basically they just, after that, you're gone. If you get sick with COVID and you get out, look, you just out of work. You can go and you can try to, file for unemployment and stuff like that, but ask around, and see what nurses were getting when they were off for weeks at a time for being infected with COVID, and see. And what you're going to hear is nothing. You play catch up when you come back after your infection. That's what you do. If they may give you some, if you've got sick time, if you don't have sick time, then hey, it's on you. I can tell you what it's like when you're on workman's comp. You're working for half of what you worked for before. So, you're at a deficit. And when you come back, that's why most of the time, most of us go back in, we're working hurt, we're working sick, because we cannot afford to not work, just like most other people in the workforce. So let's finish this up. All right. Okay, well, here we go. Persistent staffing shortages caused by the pandemic have forced hospitals to increase their use of contract workers, of nurses, technicians, and other essential positions. Unfortunately, some staffing agencies are exploiting the severe workforce shortage by charging uniformly high rates and retaining up to 40% or more of those amounts for themselves. The conduct of some of these staffing agencies could suggest widespread coordination and other abuses, which is why the AHA and congressional lawmakers are asking federal agencies to investigate possible collusion and price gouging. Okay. Meanwhile, some suggest there should be rigid nurse-to-patient ratios, like I was just talking about, which they are not. You never know what you're going to get when you come in, not to mention what you have in a large number of patients, and then they start adding admissions, along with that. So you have your caseload and then admissions, and then, if you don't complete that, you get harassed for being too slow and not being able to, complete your work in a timely manner. So then we have, it says, we strongly believe that nurses need to be empowered with flexibility to determine appropriate staffing for the needs of their patients. What do you think is going to happen if I was to say, okay, I don't feel comfortable with this number of patients. I don't feel that this is safe, which, as a nurse, you should be able to say, according to the boards and according to any nursing program that you go into, you should be able to say that. Texas has a safe harbor law where basically you can say safe harbor, because I have too many patients. If anything goes wrong, I'm declaring safe harbor because I'll still work and I'll try to do my best in this situation. But this is not appropriate at all. Okay, so provides some protection for the nurse who was put in that bad situation. Okay. Other states don't have that. My state doesn't have that. I think that should be a nationwide deal because, most states work their nurses exactly like that. In California, they have unions out there. So if they try to give you more patients than you're supposed to have, they go on strike. If they have you out emptying trash and doing other things that don't have anything to do with nursing, they go on strike. And I don't blame them. Okay. A one size approach does not fit all when it comes to safe staffing, and strict, inflexible approaches will exacerbate the workforce shortage crisis. Our workforce challenges are a national emergency that demand immediate attention from all levels of government and workable solutions. These include lifting the cap on Medicare-funded physician residencies, boosting support for nursing schools and faculty, providing scholarships and loan forgiveness, and expediting visas for all highly trained foreign healthcare workers. Okay. So they're trying to take off the pressure by trying to recruit people from other countries rather than allowing for more American staff. So I don't like that. If they need more staff, there are plenty of people here who want to be nurses. There are plenty of people here that want to be doctors. But there are certain people that I feel they still don't want to be doctors and nurses. Ask around, listen to some of the stories of those that'll tell you it's out there. Okay. In addition, we must support state efforts to expand the scope of practice laws to allow healthcare professionals to practice at the top of their license. We also need to stop health insurers' burdensome bureaucratic practices that take caregivers away from the bedside. Exactly. And some of that is basically some of these health insurers basically dictate who they will listen to with regard to documentation and all of that in order for them to pay. Okay. So they can say, we want, a special type of, RN, with butterfly wings in order for you to get paid. And then everybody else who is a caregiver in that scenario of that patient's care, are deemed to be inappropriate and inadequate for that facility to get paid. So that means that drops our pay, that drops our importance in the rendering care for that patient. And that's inappropriate. That shouldn't be the case. We all are professionals. We all go to school. We all have been trained to do that job, and for healthcare, insurance providers to try to dictate how care is rendered and what they're going to pay for and what they're not going to pay for is manipulative at best. But we've been dealing with this for the longest. So, the people who work in the hospitals and health systems are truly the heart of healthcare. We must support them and stay focused on keeping our patients and communities safe and healthy. Okay, that's what the American Hospital Association is saying about it. So, let's see what the nurses are saying about it. Okay. Here's another article here in Healthcare Dive. Okay. And they're talking about burnout from working through the pandemic continues to drive nurses to quit their jobs. And more than a third of nurses recently surveyed by staffing firm Incredible Health said they plan to leave their current jobs by the end of this year. According to a report out Wednesday, nurses cited burnout and high-stress work environments as the number one reason for leaving their jobs, followed by pay and benefits. Sounds a little different from the American Hospital Association's version of it, huh? Okay, among those leaving or planning to leave, higher salaries are the top motivating factor for taking other positions. Nurses are also leaving for other jobs with greater flexibility and opportunities for career advancement, according to the survey. Okay. Did you guys know that most nurses who work don't get raises? They continue to work at the same level of pay that they were hired at forever, for as long as they're at that job. So if you get hired at, $28 to $30 an hour, you're going to be working for $28 to $30 an hour for, the 5, 10, or 20 years that you're there. You'll get little plaques, you'll get little knickknacks and whatnot. You'll get some lunches, for, well, not lunches, because, most of the time you can't take a lunch. Sometimes, I'll say 90% of the time, you can barely go to the bathroom because you have so much charting to do. You have so much work to do, but they don't tell you that, all right, let's move down to the dive insight. Let me quit crying. Dive insight. Hospitals are currently battling some of the worst staffing shortages they have faced since the pandemic began, as burned out healthcare workers continue leaving their roles. Many are quitting to take higher paying traveling nursing positions or opting for early retirements as systems attempt to wrangle in heightened labor expenses. Burned out is the key factor causing nurses to quit, followed by pay, though in general, salaries haven't risen substantially according to Incredible Health reports, which, based on data collected through its platform along with a survey it conducted of more than 2,500 nurses in February, instead of boosting salaries to recruit and retain staff, systems have opted for sign-on bonuses. They'll give you like a $5,000, $10,000 sign-on bonus, but you have to work for so long before you get that. And then when you get it, they give it to you in pieces that are individually taxed. So it doesn't really come out to what it actually is or what you agreed to. Those sign-on bonuses. Okay, the number of offers include such bonuses rose 162% over the past year, according to data from Incredible Health's platform. In Texas, 58% of offers included sign-on bonuses in 2021 compared to 16% in 2020. And bonuses nearly doubled in value from 5,800 to 10,700. Like I said, I didn't even have to read it. Okay, but salaries in the state overall decreased 5% over the past year, according to a report. Meanwhile, California has the highest nurse salaries, which are about 20% above the national average. That's why that's one of the best places for you to go travel. Everybody's trying to travel to California. Okay. Sign-on bonuses have been effective in enticing nurses to relocate for new positions. Interview rejections due to location decreased 28% over the past year. According to the report, as the healthcare workforce continues to undergo some major transitions 2 years into the pandemic, issues with traveling nurse staffing continue to serve as a key pain point. They're commanding much higher rates than permanent staff. This is what I was talking about earlier. They can pay you for going in and working for them for whatever company or facility. They can pay you much less, and they will try to do that before they will pay agency. So if they get an agency that's bidding, and even if they have, a short staffing, they'll pay for agency for a little bit, but then most of the time it's not gonna be very long, or they'll pay for just enough to get by, but not to adequately staff the facility. So you're still working short. You're still putting your license on the line, and patient safety and everything that you're supposed to be trying to do is basically being jeopardized. But you still work like a flaming demon trying to get everything done, and you can't leave on time. You can't go to the bathroom, like I said. You can't eat. The facilities don't feed you. Thank God for Grubhub. You're basically drinking coffee and energy drinks, trying to complete tasks as one nurse that should be taken care of by 3 nurses. That's the problem. And that's been the problem for about the last 3-4 years. It's just been steadily getting worse. And they're blaming it on the nurses wanting to get paid more and all of that, the hospital association, and blaming the agencies. But when you talk to the nurses, it's a whole different story. Okay, let's move on. Okay, they're commanding much higher rates than the permanent staff, spurring some to leave for those roles elsewhere and causing more problems for those who stay. Okay, among the nurses surveyed, 77% said they've seen an increase in travel nurses in their unit over the past year, and 33% said that's caused an increase in dissatisfaction among permanent staff, the report found. Okay, now the reason for that, okay, I'll give you a prime example. I could be at my job, I could be making, say, I'll just throw in a number. I'll just say $28 an hour. Okay, and they will hire in another nurse from the agency, and that nurse may be making $38 an hour to come in there and do what I do, or to assist me. But I'm working for half of that, which causes, most people, when agency nurses to come into a place, these people will mistreat the agency nurse or won't show the agency nurse how to do certain things, and they'll sabotage that agency nurse because they feel like, well, if you're making that much money, you should be super nurse. Now, you shouldn't do that, and not all of us do that. I mean, I don't do that. I mean, I'm like, if you're here, you know what, get that money. I'm not mad at you. And if I want to get that money, all I got to do is just, go and sign up with the agency. That's the nature of the beast. If you want it, you go get it. That kind of goes off into this argument about, whether, females are hired the same amount as males. Well, I can tell you that I know some people out here who are working some crazy amount of hours, and they're getting crazy amounts of money. And then you have other people who are doing the exact same job, who are of the other persuasion, who say that they're never going to work that much because they rather have free time and all of that. And that's why these people are not making the amount of money. Now, that goes whether you're a guy or a girl, but there are some guys that say that they're just not worth it for them to do that. So here's one of those situations where this is why people are not making the same amount of money. So that's a whole nother situation, but a good example. All right. Compensation differences were leading cause of dissatisfaction, and the culture of a unit changes amid influxes of temporary staff, nurses reported. At the same time, nurses said patient frustration, racism and discrimination and assaults are on the rise, particularly due to ongoing COVID guidelines. Some 65% of nurses said they had been verbally or physically attacked by a patient or patient family members in the past year, the survey found. Now, if you don't know, I was attacked at the job here also within the last 2 months ago. And was injured pretty bad. So I couldn't, you can't protect yourself. All you can do is just, you can't strike back. You can't do anything. All you can do is just try to subdue that individual and, call the police and whatnot, but you're still injured and you still lose money. And the job doesn't treat you well when you come back. So, yeah. All right. So while 52% attributed to the pandemic restrictions, 47% said it's a result of longer wait times and other issues caused by a lack of staffing. Yeah, that's true. If not, a higher percentage. Okay, current staffing shortages are so troublesome that they're the top patient concern for 2022. According to another report on Monday from Healthcare Safety Organization Emergency Care Research Institute, ECRI researchers said shortages are actively jeopardizing patient safety, with many patients waiting longer for care, even in life-threatening emergencies. That's true. Okay, there's another article. I'm going to throw one more in, and this is by EBN. Okay. This one, too little, too late. 500K nurses are leaving the bedside by the end of 2022. All right. Before the pandemic, Brittany Kennedy, a licensed practical nurse, was working for a family and their child, picking up shifts as she and they needed. But as the spread of COVID-19 began to stroke fears and the workforce and force workers and families into isolation, Kennedy's assignment ended, and she was thrust back into the front lines in order to support herself financially. The scene she was met with could only be described as a disaster. Anywhere I went, we didn't have any personal protective equipment, says Kennedy, who primarily worked in Philadelphia area nursing homes. We couldn't care for these patients like we wanted to, because we had to keep ourselves safe as well. Once PPE finally arrived, she remembers layering in gowns, N95 masks, goggles, gloves, and face shields in the hallways between patient rooms. In between every patient visit, Brittany would peel off a layer after layer so she could wash her hands and sanitize herself as best she could before putting back on the same used PPE due to a nationwide shortage. Already brutal double shifts turned into triple shifts as other nurses walked away from the pressure and started skipping their rounds, forcing workers like Kennedy to stay on until proper relief arrived. It's a common occurrence that nurses called being mandated, which refers to mandatory overtime. It's strictly prohibited for hospitals to require mandatory overtime unless there's a healthcare emergency like a pandemic. That's true. Okay. A lot of people don't know that if you don't have relief as a nurse, you can't leave. And a lot of times in snow and, bad weather situations and stuff like that, nurses get stuck like that. And with this pandemic, trust me, I've worked a bunch of doubles. I've done my share, as well as a lot of other people out here. And I'm going to tell you, they are not fun. I'll just leave it at that. It happens. Kennedy says you're already tired and worn out from going through this process, and then you have to do another 8 hours of it. Okay. The understaffing of hospitals and nursing homes was nothing new to Kennedy and her fellow nurses, but the severity of the situation reached new heights during the pandemic, and this community of caregivers started to feel helpless. The added strain caused many healthcare workers to lose their passion they previously had for the job. That combined with the realization that they could make the same amount of money, if not more, on unemployment, spelled catastrophe for staff and patients alike. They were getting paid the same doing nothing versus working, Kennedy says. I know a few people who said they're not returning to long-term care because of how COVID has affected them. They're just not doing it. It was a very, very stressful year. Yes, it was. We lost nurses and doctors alike. They aren't even addressing the suicides, doctors, killing themselves and whatnot. I think one of them made the national news. There are other nurses who I've seen people just, just leave or sit out in the parking lot, and just look at the place. Can't bring themselves to even come into the place. Burst out into tears, just having, just breakdowns, and it's funny, but it's not funny. You laugh because you're like, shit, I'm almost there too. It's that bad, y'all. And right now, I'm going to save that to the end. Okay. Typically nursing schools graduate about 188,000 new nurses each year. But by the second year, the workforce, 33% leave the bedside due to burnout, according to data from the nursing agency IntelliCare. Post-pandemic, those statistics have become even more damning. The U.S. Bureau of Labor and Statistics projects that 500,000 seasoned nurses are expected to retire between now and the end of 2022, creating a shortage of 1.1 million nurses. It's a mass exodus that has been accelerated nearly 20 years by the pandemic, according to David Coppin, co-founder of IntelliCare, a digital staffing agency for nurses. The culprits, Coppin says, are the very institutions that employ nurses. I totally agree. These institutions have been flipping nurses off for years and basically doing whatever they want and basically just, either firing you or, basically just continuing to disrespect you just ad nauseum. Okay, the nursing shortage is being driven by the healthcare facilities themselves. Coppin says the way the nursing model is working is just broken. They can't handle it anymore. They feel like they're constantly on call, even if they're technically not. I'll give you a primary example. I had an admission the other night. Okay, did the admission, and I completed a section of the admission, a part of the admission, gave report to the other nurse that came in, And that nurse didn't do anything on that mission all night long. So I was called at 8 that next morning and told to come in and to complete that admission. So I came in. I was written up for not completing the admission. I completed the admission. That nurse also was written up. I was written up. Now, there's a thing called continuity of care in nursing, where if one nurse can't finish a job within their time period, then the next nurse picks that up at the level. I mean, at the point where you couldn't complete it, and then completes the task. And if that person can't complete the task, is moved on to another nurse, and each nurse completes a piece, and that way you don't overwork nurses. Well, that didn't take place, and I'm also still working on light duty because I was injured at work by a patient. Okay. So that's the kind of stuff that we have to deal with. Okay. So here's another one. Who cares for caregivers? Earlier this year, Erin Clifford was finishing up her last months as a nursing apprentice when she felt an overcoming panic attack during one of her hospital shifts. Recognizing the symptoms, shaky hands and rapid heart rate, hyperventilation, she took herself down to the ER and checked herself in, where she was given a shot of the anti-anxiety drug Ativan and told that she couldn't drive, much less continue to work. Following the doctor's orders, Clifford went home after filling in her colleagues who were understanding of the situation, but her discussion with her nursing director was less accommodating. Her exact words were, "You left the floor short-staffed that day and you didn't find somebody to cover your shift." Oh, let me tell you, I can't believe I forgot that one. Yeah. And not only if we call in, we are required by some facilities to call someone to cover our shift, or we're still responsible for covering that shift. I've even worked at a place where they told us, we don't accept call-ins. If you call in and you're sick, no, I'm not accepting your call-in. That's what they'll tell you, And that's the type of environment that we work in. No one else has to deal with that type of stuff, But yeah, let's read her account. So then, you left your staff. Okay. You didn't find somebody to cover your shift. Clifford says, "I was taken back by that. It wasn't, 'Are you okay? Did anything happen? Did you get hurt? Did a patient get hurt? General humanity? There wasn't any of that. Clifford only had 2 shifts left with that hospital in total. And for both, she called out. Now she's moving forward with her nursing career and says that overall she's excited about the future, but the lack of empathy is a fresh memory and she hopes to see change in the future." Yeah, she's fresh. Yeah. Thank goodness for that. Okay. She says, "I don't want to say it's falling on deaf ears," she says of nurses' plea for a more equitable workplace, "but it's falling on ears who hear it and they see it and then they write it down. But when it comes down to it, they're so scared and they don't want to upset the people who give them their budget and their money. But that's not what it's about." And that's not what it's about, but it kind of is what it's about. It is about the money. And the longer you work in the field, you'll see that it's all about the money. They can replace you in a hot second. If you fall, they call you in on a snow day and you run off the road and are killed. Guess what? They ain't gonna miss 2 breaths. They're gonna call somebody else in, and they're gonna move on. I've seen it multiple times. Okay, so Clifford and Kennedy aren't alone in their burnout. 76% of nurses feel the same exhaustion. Of those who walk away from their profession, 59% cite insufficient staffing levels as their top reason for quitting. 56% of the demanding nature of their job, 54% of the emotional toll, 51% because they don't feel supported by their managers, according to a McKinsey survey. All right. We're the ones getting our hands dirty, Kennedy says. When decisions are made by other people, it affects our lives, and they're putting on more and more and more for us to do. It's not realistic. It has always been stressful, but now even more. Okay, the scramble for solutions. To keep nurses from being overwhelmed or overworked, they must retain control of their schedules, says Intelli's chief clinical officer and registered nurse, Rebecca Love. If the industry keeps on its current trajectory, she warns, people are going to die. You saw it in Dallas. You saw it in Houston. She says, referencing the nursing shortage Texas experienced during the pandemic that left 23,000 nursing positions unfilled. According to a labor analysis by the Texas Workforce Commission, you're seeing emergency rooms that don't have enough providers to provide care. You're seeing medical officers at hospitals standing up and saying patients are going to die because we don't have enough providers. Beginning in April 2020, Texas spent $5.36 billion in federal relief funds to attract nurses away from their home states to support local facilities overwhelmed by COVID. Nearly a year and a half later, in August 2021, cases and deaths were still rising month to month in Texas. There is an incredible amount of burnout, stress, and trauma on these providers that we've never seen before, Love says. People will say, oh, but you're a nurse. You must deal with people who die all the time. And we do. But what we don't usually deal with is the scale of death or traumatic form in which people are dying in front of us. Now, as the pandemic is starting to subside, the death rates have plummeted. It's easy to assume relief for this workforce, but we're only starting to understand the aftermath of COVID, Love says. Nurses have become painfully aware that they're working for a system that is ill-equipped to support their needs. The situation is so absolutely astronomical in its severity, Love says. Hospitals are so focused on saving patients' lives that they're not coming up with good solutions on how to do it. And the truth is, it's because we kept thinking there were always going to be more nurses. Okay, the industry isn't just struggling to retain veteran nurses, but fresh graduates too. Nurses younger than 35 who have been at their current employer less than a year are most likely to leave voluntarily, according to a new analysis. They're not even making it a year. They used to give us 5 years. They used to say after 5 years, you burn out. Now they're only giving you 1 year. Some of them ain't even making it a year, y'all. Okay. Likely to leave voluntarily, according to a new analysis by Press Ganey, a leader in healthcare consumer and workforce engagement. New hires specifically are at the greatest risk for turnover due to weaker connections with their team managers and organizations. That's true. Yeah, it used to be a lot of camaraderie in it. There used to be a lot of friendship in it. People used to, go to lunch, go to dinners together and hang out together and stuff. All that's all gone. Okay, creating more control. To remedy the issue, organizations like IntelliCare are fighting to put nurses back in the driver's seat of their own careers. The nursing agency gives nurses a pathway to becoming agency workers, which allows them to provide to be considered as W-2 workers with full access to benefits, but allows them to choose when and where they work via a digital app. Facilities send Intelli their opening shifts, and Intelli sends them to corresponding nurses. With matching availability. Okay. These kinds of solutions having immediate impact. Kennedy has been an Intelli nurse for 2 of her years in healthcare, and although she still experiences regular bouts of burnout as an agency nurse, she does feel she has more flexibility and control, a luxury most nurses don't. As an agency worker, she's not confined to one place, much less a schedule. And there's a third-party team tracking her hours to ensure she's not clocking in too much overtime. Still, the pros of being an agency nurse doesn't always outweigh the cons. And Kennedy admits she's considered walking away from the profession she's loved. Nursing, she says, is not for the faint of heart, and the industry can't keep up with the current level of churn. The simple fact is that everybody can't do this work, she says, and it's not the same as when I first started doing this. It's totally different. As much as I love being a nurse and helping people, I'm at the point that I don't even know if I want to continue to be a nurse. I can't tell you guys how much I have heard this from most of the nurses that I know. This is the exact statement. Everybody's saying the exact same statement. I don't even know if I want to be a nurse anymore. I hear it over and over and over and over and over. Okay. But for now, Kennedy is moving forward with caution because she can't shake the passion she has for the work. She's hopeful that the industry can change and that the landscape of care can change and that more services will be made available to support her own needs as a worker. I do it for people's grandmothers and grandfathers that are dying. The parents that can't feed themselves, she says, that's who I do it for. And it's hard when you've got to work and you're faced with so many obstacles. But then at the end of the day, I'm here for patients. That's true. That's who we're here for. That's who we do it for. I'm going to cover a couple of other little deals that's gonna go in here. This is kind of going long. Hopefully not too long. Hopefully this was informative for y'all. But here is what's going on here. Crap. Okay, there it is. Okay, Arkansas's active COVID cases topped 10,000 for the first time in 4 months. Okay, that's one deal there. Okay, all right. Well, I'm not going to read that, but I'll add it. Okay, I'm going to show you what's going on here. With COVID here. There we go. New cases shoot over 1,000 for the second straight day in a row. Okay, this is 2 days here. There was a break in between, and then there was 2 days before that. So that's 4,000 cases. Okay, so we're seeing the number of cases are up. Before the flu season ever hit. We're not even supposed to be seeing this kind of numbers during the summer months, the spring months, but we've been inching up, down here, down south. Nobody's talking about it. Some places are basically taking down their shields and a lot of people aren't wearing masks. Today I had to take my wife had to take the car in. And, the place where we usually take our cars in, Usually has like a shield to protect from, droplet protection and whatnot. And people are required to wear masks and separate themselves. They've stopped doing that. But yet the numbers are going up. Okay. 1,000 cases, second straight day. Okay. Arkansas COVID hospitalizations hit a 15-week high. New COVID cases, again, top 1,000. All right. Okay. That's where we are. All right, here's another one where they're talking about Jeff Perry changed roles many times when the COVID-19 pandemic left his Tennessee school district short of staff. More staffing shortages. Okay, there's another story here. This was the last 19 hours. Arkansas count of COVID coronavirus cases rose Thursday by 1,420 cases, the second highest daily increase since February, and the fourth one in the past 2 weeks. That was in the quadruple digits. Okay, that's where we are here. Okay, there is the Arkansas Department of Health's release on the number of total cases. Change in the last week. 6,516. Total cases for today. Well, that was on the 28th, actually. That was 1,839. Total deaths, 24. Total deaths, total deaths for that day was 24. Total deaths, 11,574. Okay. There you go. Got your ventilators, ventilator usages. We got 10. Okay. -5. Okay. Currently hospitalized. We've got 211, up 33. Okay. Those are not, those aren't small numbers. The deaths are still up there. The total deaths anyway. So those numbers are not unsignificant. So I wanted to throw that in there, and I'm throwing that in there to say that basically, we're dealing with these things, and they're talking about staffing shortages. They're talking about huge numbers of patients. We are working to try to get through these things, yet this, that's another aspect of what's out there. So this is just another thing to add on top of that. Everything's getting more expensive. We've got impending doom with our financial system. Our healthcare system is headed towards its own impending doom. We've got a lot of things headed in that direction. We've got food shortages, we've got water stress, we've got all these things happening, and people are acting like we should just continue to go take trips and live our best lives, and it's all over. We're all out here having a party. The pandemic's over and whatnot. And that's not the case, and it's just more unrealistic activity, regardless of, facts, data, and statistics. This is just not a good thing. And I'm just basically trying to shine a little bit of light on this to give you guys a look at least my little corner of the world, to show you some of the things that you don't hear about, that we have to deal with when trying to save people's lives. I hope you guys found this to be informative, and I will continue to cover the COVID situation and some of the other healthcare issues that will affect our community and our country. And I hope you guys found this informative. Like I said, hit the like button, share button. Stick with me. I'll try to crank out as much of this as I can. But like I said, they're killing me. They're working me to death. I'm just lucky I didn't get out at 3 a.m. as usual. So, like I said, hope you guys enjoy it, and I'll see you guys next time.
I feel like a motherless child a long way from home. A long way from